Good morning and welcome back. Myself Dr. JIBRAN Ahmed presents to you Simply Pathology, and today we are back with a very important and interesting topic, normal hematopoiesis. So today's topic of discussion is a very important one, wherein we are going to discuss the basics of hematopoiesis. We are going to discuss how basically our blood cells are formed. We are not only going to discuss the process of blood formation, but we are also going to see the different blood cells. So let us begin without wasting any time. So remember, the normal hematopoiesis is nothing but it is a physiological process of formation of blood cells. Okay, now the blood cell progenitors, that is the primitive hematopoiesis, first appears in the yolk sac during the 3rd week of embryonic life. Okay, so the primitive hematopoietic stem cells, okay, they first appear in the yolk sac during the 3rd week of intrauterine life, and it is transient. So primitive hematopoiesis that occurs, okay, it is transient and it mainly occurs in the form of embryonic red cells. So what are the embryonic red cells composed of? Which type of hemoglobin is present in the embryonic red cells? They are Gower 1, Gower 2 and Portland. So these are the embryonic hemoglobin. So the primitive hematopoiesis is first beginning in the 3rd week of intrauterine life in the yolk sac. Okay, but remember that the definitive hematopoietic stem cells, they are arising several weeks later in the mesoderm of intraembryonic region, intraembryonic AGM region, that is aorta, gonads, mesonephros region. So I repeat once again that definitive hematopoietic stem cells, they arise several weeks later in the mesoderm of intraembryonic AGM region. AGM stands for aorta, gonads, mesonephros. Now remember, during the 3rd month of embryogenesis, hematopoietic stem cells migrate to the liver, which becomes the chief site of blood cell formation until shortly before birth. So it is during the 3rd month of embryogenesis that the hematopoietic stem cells are traveling to the liver, and it is at this time that the liver starts synthesizing blood, and it is the chief site of synthesis of blood during the intrauterine life just shortly before birth, okay, wherein the hematopoiesis in the liver completely stops. Now by 4th month of intrauterine life, okay, hematopoietic stem cells, they shift in location yet again, and this time they are relocating to the bone marrow. By birth, remember, by birth or at the time of birth, the bone marrow throughout the body is active site of hematopoiesis. Okay, so hepatic hematopoiesis becomes inactive soon after birth. So I know this is very confusing. Just to clear the doubt, okay, from which age to which age hematopoiesis is taking place in which organs, let us see. So from the 3rd week to the 3rd month of intrauterine life, it is taking place in the yolk sac. From the 3rd month till shortly before birth, it is taking place in the liver, whereas from 4th month onward, okay, till birth, okay, and till the time of birth, okay, the bone marrow becomes a major source. So remember, hematopoiesis in the bone marrow, it is starting at 4th month, okay, but it becomes the major site of hematopoiesis at birth, and hematopoiesis in the bone marrow is continuing lifelong. Okay, so remember one important point: at a younger age, whole of the bone marrow in our body, whole of the skeletal marrow, including the long bones and the flat bones, are participating in the process of blood cell formation. But by late adulthood, that is after puberty, hematopoiesis is restricted to the flat bones. What are the flat bones? The sternum, ribs, iliac bones, vertebrae and the proximal ends of long bones. Okay, remember, our body is composed of 2 types of marrow. One is an active marrow, which is the red marrow, okay, whereas we are having an inactive form of marrow that is called as the yellow marrow, which is containing mainly fat. Okay, so this is all about the hematopoiesis. Now we will discuss about the hematopoietic stem cells. What are the properties of the hematopoietic stem cells? Let us see. So remember, in normal adults, only about half of the marrow space is hematopoietically active. Now remember, whatever blood cells are present in our body, all the formed elements of the blood, that is the RBCs, the WBCs, okay, including the neutrophils, monocytes, platelets, lymphocytes, they are having a common origin from hematopoietic stem cell. Now these hematopoietic stem cells are having very important property. 2 very important property is there. Number 1, they are pluripotent in nature. Now, what is the meaning of pluripotent? Pluripotent means it is the ability of a single hematopoietic stem cell to generate all the mature blood cells. So a single hematopoietic stem cell is giving rise to all the cells, whether it be your myeloid series, whether it be your lymphoid series. It is giving rise to all of them. Okay, that is called as pluripotency. And they are also having the capacity for self-renewal. What is the meaning of self-renewal? So when a hematopoietic stem cell is dividing, at least one daughter cell will self-renew and avoid stem cell depletion. So whenever a cell divides, okay, there are two cells which is formed. One cell is going towards the path of differentiation and they will form either myeloid or lymphoid series, whereas one more cell that is there, it will divide and form hematopoietic stem cells only. Okay, so these are the two important properties of hematopoietic stem cells. They are pluripotent, that is ability to generate all the blood cells, and they have the capacity for self-renewal. They preserve their own population. Now remember, hematopoietic stem cells, they are not sessile, means they are not quiescent, they are not just resting. Okay, particularly under conditions of stress. Okay, for example, there is a lot of bleeding or there's a lot of hemolysis. Okay, in those situations, the hematopoietic stem cells are mobilized from the bone marrow and they enter the peripheral blood. And this property of the hematopoietic stem cells forms the basis of bone marrow transplantation in today's age. Today, the bone marrow hematopoietic stem cells are collected from the peripheral blood. Okay, and how they are collected? They are basically collected in response to the granulocyte colony stimulating factor or the hematopoietic growth factors. So in today's age, we are giving hematopoietic growth factors to the donor patient, and these growth factors are mobilizing the hematopoietic stem cells from the bone marrow into the peripheral blood, and it is from this peripheral blood that the hematopoietic stem cells are harvested, okay, for transplantation. Now these hematopoietic stem cells, they form 0.5% of the total hematopoietic precursors. Now remember, what are the markers of hematopoietic stem cells? These are CD34, they are CD34 positive, they are c-KIT positive or CD117 positive, and they are lin negative. These are the markers of hematopoietic stem cells. Now after the hematopoietic stem cells comes the multipotent progenitors and early committed progenitors. Let us look at what they are. So these hematopoietic stem cells, they are going to differentiate and form multipotent progenitors. So what are the features of multipotent progenitors? They are forming 3% of the precursor or primitive cell population. And how is it different from the hematopoietic stem cells? These are more proliferative than the hematopoietic stem cells, but they are having lesser capacity for self-renewal. Mark my words. How is it different? They are more proliferative than hematopoietic stem cells, but their capacity for self-renewal is less. Mind it, both the hematopoietic stem cells as well as the multipotent progenitors, they have the capacity of self-renewal, means they can maintain their own population, because with every division, one cell is going to go towards differentiation, whereas other cell is going to form the same type of cell. That is, one hematopoietic stem cell will give rise to multipotent progenitor, whereas other will form hematopoietic stem cell only. Okay, similar is the case with multipotent progenitors. Now for example, one multipotent progenitor will give rise to two cells. One of them is going to differentiate into progenitor lymphoid or myeloid, and another one is going to form multipotent progenitor and preserve their own population. So after the multipotent progenitors comes the early committed precursors. So these are also progenitors, but they are having a limited capacity of differentiation. For example, we are having early progenitor which is having lymphoid potential, that is, they are going to give rise to lymphocyte series, and they are having early progenitors with myeloid potential where they are going to give rise to granulocyte series, for example neutrophils, monocytes. Okay, so these are committed. So these early progenitors, they are committed progenitors that have lost the ability of self-renewal. They cannot self-renew, they have to differentiate, that are going to differentiate further, giving rise to certain units called as colony forming unit. So what are these colony? For example, the early progenitor lymphoid series will give rise to a colony forming unit of T lymphocyte, colony forming unit of B lymphocyte, colony forming unit of natural killer cell. Similarly, your myeloid progenitors will give rise to colony forming unit of neutrophils, okay, monocytes, megakaryocytes, okay, RBCs, okay, so like this. So they will produce, and why they are called colony forming units? Because they are going to produce colonies which are composed of specific kind of mature cells. Okay, now there is one more important property that I wanted to highlight, which I couldn't in the previous image, so I have made this image again. So what I wanted to show over here is that once these committed or early progenitors, okay, they are finally going to form mature blood cells which comprises more than 95% of all the hematopoietic cells. Okay, and remember, as they are going to go down, okay, as they are going to differentiate from early progenitor towards the mature blood cells, they will have an increased proliferative capacity, they will have increased cell division, they will have lineage specific growth, they will have no self-renewal capacity, and they will have increased differentiation. And as they will go down, they are going to develop lineage specific markers. For example, lymphocytes will have their own set of markers. Okay, myeloid series cells will have their own set of markers. Then also over there also there is differentiation. For example, monocyte series will have its own set of markers. Okay, erythrocyte series will have its own set of markers. So different cells will have their own set of markers. Okay, so this is the basic diagram, and this has been taken from Robbins only. So you can see at the top we are having the hematopoietic stem cell, then is the multipotent progenitor, and both these cells have one thing in common, that they have the capacity of self-renewal. Okay, and one important difference between multipotent and hematopoietic stem cell is that the multipotent stem cell or the progenitor, they have a more proliferative capacity and a lesser capacity of self-renewal compared to the hematopoietic stem cells. After this point, whatever early progenitors that we are going to see, they have lost the ability of self-renewal. So for example, here the early progenitor with lymphoid potential are going to give rise, okay, they are going to give rise to progenitor NK cell, progenitor B cell, progenitor T cell, and then they are going to undergo further differentiation to give rise to precursor NK cell, precursor B cell, precursor T cell, and again they are going to further differentiate into natural killer cells, B cells, and mature T cells. So this is how the lymphopoiesis is going to happen. This is the basic hematopoietic lineage of lymphoid cells. Now what happens at the end of the myeloid series? So myeloid series are going to form certain colony forming units. First is a colony forming unit which is having a mix of colony forming unit granulocyte, monocyte, and eosinophil. Now this colony forming unit granulocyte is going to give rise to myeloblast, and that is going to differentiate and give rise to neutrophil series, whereas the colony forming unit, okay, monocyte is going to give rise to monoblast, which will ultimately give rise to the mature monocyte. Similarly, colony forming unit eosinophil will give rise to eosinophiloblast, that will give rise to eosinophils. Okay, now again we are having the colony forming unit which is basophil, then megakaryocyte, and lastly we are having erythrocyte series. So the colony forming unit basophil is going to give rise to basophiloblast, that will give rise to basophils. Colony forming unit megakaryocyte will give rise to megakaryoblast, that is going to give rise to platelets, and colony forming unit erythroid series is going to give rise to erythroblast, that is ultimately going to give rise to the RBCs. So this is how our basic hematopoietic process is going on. Now as you are going to see, as down the lineage the cell division or the proliferative capacity increases, lineage specificity and development of lineage specific markers increases as you are going to go down. Okay, now let us discuss about certain hematopoietic growth factors. Now what are hematopoietic growth factors? These are nothing but they are a group of protein that regulates the proliferation, differentiation, and maturation of the progenitor cells. They can also influence the commitment of a progenitor to a specific lineage, and they affect the function and survival of mature red cell or mature blood cells. Now what is the source of these growth factors? There are many sources. I have taken some common sources. Common sources of growth factors are the T lymphocytes, macrophages, fibroblast, endothelial cell, livers, and kidney. Okay, now growth factors can be divided into two types. One is a lineage specific growth factor, that is some kind of growth factor that is going to promote the growth of a single type of a cell. For example, erythropoietin is going to stimulate the growth of RBCs only. Thrombopoietin is going to increase the growth of platelets only. Granulocyte colony stimulating factor is going to increase the growth of granulocytes only. Okay, wherein we are having other types of growth factors like lineage independent or multilineage hematopoietic growth factors. For example, we are having granulocyte monocyte colony stimulating factor, which is going to stimulate the growth of multiple lineages. Over here, the granulocyte series as well as the monocyte series. Okay, now we are going to start the process of erythropoiesis. Now you have already read about this process. You know what erythropoiesis is. It is nothing but it is a process of formation of RBCs. Okay, so basically over here, if we are going to see, this is basically an erythroid island. What we are going to see over here is that there is an erythroid island. So what is an erythroid island? First of all, this is an image which is taken from a bone marrow, and it is showing a particular erythroid island where there is a collection of erythroid progenitors or precursor cells. Okay, and in the center of this island you can see that there is a macrophage. So why is it that all the RBCs are surrounding this macrophage? Okay, so first of all, what is an erythroid island? Okay, within the bone marrow, the erythroid progenitors are found in the form of island, that is called as colonies. And erythroid island is composed of erythroblast, which is surrounding a central macrophage. Now the more immature precursors of the erythroid series are present closer to the macrophage, and the maturing forms are towards the periphery of this island. Now these macrophages, they are having certain dendritic processes which is extending between the erythroid precursors, and they are basically providing support to the erythroid cells, and they are supplying iron for hemoglobin synthesis within the erythroid cells. So basically these macrophages are providing support and growth to these immature erythroid precursors. This is a classical image of an erythron or the erythroid island. What can we see over here? This is this one which is the center. It is the mother, it is the macrophage which is providing nutrition to the immature RBCs. Immature RBC, these are the nucleated RBCs. Okay, these are the immature RBC precursors. You can also see one of this process of the macrophage is extending between and providing support to the immature erythroid series. Okay, so there is a very important common point that we have to note during erythropoiesis. So with each stage of process of erythropoiesis, the cell size and the nuclear size becomes smaller. There will be chromatin clumping. Okay, there will be more clumping and the nucleus is going to become more coarse. Ultimately, the nucleus is going to be excluded out of the developing erythroid series, and the color of the cytoplasm will gradually change from basophilic, that is bluish, to orangish reddish color to pinkish color. Okay, this is what is going to happen along the process of erythropoiesis. So here we are going to take a look. The first cell of the series is the proerythroblast, which is the largest cell. Now remember, for any series, the initial most cell is called as a blast, and any blast has a basic feature. They are going to have a high NC ratio, nucleocytoplasmic ratio. They will have prominent nucleoli. They will have an open chromatin, and here the cytoplasm is basophilic cytoplasm. Okay, now after the proerythroblast, we will have the early normoblast, also called as the basophilic erythroblast. Okay, these are smaller in size as compared to the proerythroblast. They do not have a nucleoli, although their chromatin is open. Okay, but they are more condensed as compared to the chromatin of proerythroblast, and they are also having a basophilic cytoplasm. After this, you will see that there is a intermediate normoblast, that is polychromatophilic erythroblast. Why they are called as polychromatophilic? Over here, if you see, the color of the cytoplasm has changed, and why it has changed? It has become grayish because of the synthesis of hemoglobin which has started in this phase. Okay, and over here, if you compare the nucleus has become more smaller, and the nucleus has become more darker, that is more compact. Okay, more coarse. Okay, no nucleoli is visible. Okay, so this is the classical intermediate normoblast, all polychromatophilic erythroblast. After this, we are having the late erythroblast, also called as orthochromic erythroblast. Here the characteristic thing is that the nucleus is becoming very pycnotic and dense, and the cytoplasm is classically reddish pink in color, that is well hemoglobinized cytoplasm is there. Okay, after this, the nucleus is completely extruded out. thrown out, and here we are having what is called as a reticulocyte. It is the position, okay, these are the late erythroblasts. They are excluding the nucleus to become the reticulocyte. Okay, just remember one thing, that these are just precursors of the mature RBCs. Okay, they remain in circulation from 1 to 2 days, and they have characteristic bluish tinge in the cytoplasm because of the presence of some RNAs, and they are going to lose this RNA, and in 1 or 2 days they are going to mature to give rise to a mature RBC which lacks any kind of nucleus. Okay, and the size of the RBC is similar to the nucleus of a small lymphocyte, and the central 1/3 pallor is there. The central 1/3 pallor is there in the mature RBC. Now this is not enough. Just the process of erythropoiesis is not enough. In real time, I am going to make sure that you understand these cells in real life, how they look. So this is a basic diagram of a bone marrow aspiration, and over here I am first going to show you how the proerythroblast looks like. Now if you see, if you compare, it is the largest cell, around 15 to 20 micron. It is having an open chromatin, prominent nucleoli, and a dark blue cytoplasm. In the same image, we are also having a basophilic or early normoblast. Now if you compare it with the proerythroblast, they are smaller in size, around 12 to 16 micrometer in diameter, and they have a somewhat coarse chromatin. Although their chromatin is open, but compared to the proerythroblast, they are coarse. Okay, and if you see, the nucleoli is barely visible as compared to proerythroblast, and they are deeply basophilic. The cytoplasm is deeply basophilic. Okay, now herein we can see a RBC, mature RBC also. Now if you look at this image, okay, we can see the next stage, that is the intermediate normoblast or polychromatophilic. Now how do you recognize them? Classically they are larger in size, okay, as compared to the orthochromatic erythroblast, if you see. Secondly, the nucleus is more coarse as compared to the previous stage, and classically if you look at the cytoplasm, that is grayish in color. Okay, there is a polychromasia because hemoglobin synthesis has now begun. Okay, and after this we are having the orthochromatophilic or late normoblast, which is around 8 to 10 micrometer in size, smaller in size as compared to the intermediate normoblast, and the nucleus is classically pycnotic, very dark, very coarse. Okay, no nucleoli is visible, and the nucleus becomes more small. Okay, why it is called orthochromatic? Because the cytoplasmic staining is like that of normal RBCs. That is why it is called as orthochromatic or late normoblast. Now the next stage, wherein the nucleus has completely gone out, okay, that is the reticulocyte stage. The nucleus is ultimately expelled out from the orthochromatic normoblast with the formation of reticulocyte. Now the reticulocyte, how to differentiate from the RBCs? Now the reticulocytes are having remnants of ribosomal RNA in the form of cytoplasmic reticulum that you can observe. And after 1 to 2 days in the bone marrow and 1 to 2 days in the peripheral blood, the reticulocytes are going to lose these RNA and become mature pink staining erythrocytes. Okay. Now these are mature RBCs taken in the peripheral blood. Okay, so if you can see the mature RBCs over here, and in between the RBCs you can see some pinkish dot. Those pinkish dot, they are nothing but the platelets. Now more about the RBCs. Remember, the normal red cells, they are 7 to 8 micrometer in size, and they are having smooth round contours. They are staining deep pink at the periphery, and they are paler in the center. Now the paleness or the central pallor is about 1/3 the diameter of the red cell. Now the size of a normal red cell corresponds roughly with the size of the nucleus of a small lymphocyte, and normal red cells are described as normocytic, that is of normal size, and normochromic, that is of normal staining intensity or containing the hemoglobin content. Okay, now we are going to see the process of granulopoesis. Now how does it take place? Similar to erythropoiesis, we are also having myelopoiesis. Okay, so and as I told you about the blast is a stage wherein they are going to have an open immature chromatin with multiple prominent nucleoli and a high NC ratio. That is followed by the stage of a promyelocyte, where there is a higher NC ratio. Okay, there is a more cytoplasm compared to your myeloblast, and the immature chromatin is still there, prominent nucleoli is there, but the classic important thing of a promyelocyte is the presence of abundant primary azurophilic granules. That is followed by a stage of myelocyte. Here you are having eccentrically placed oval nucleus, and the nucleus is not having any kind of indentation, but over here the chromatin is condensed if you compare with the other two stages. It is more condensed, no nucleoli is there, and it is at this stage, okay, that the secondary azurophilic granules are appearing. Now the cells are also going to undergo mitosis just up till the stage of myelocyte. Okay, now after this is the stage of metamyelocyte, wherein you are going to see that the nucleus has developed an indentation. Okay, indentation, but this indentation is less than half of the diameter of the nucleus, whereas the band form, again the indentation is there, but that is more than half the diameter of the nucleus. And lastly, we are having the mature segmented neutrophils, where the nucleus has been subdivided into 3 to 5 lobes connected by thin strands. Now the same thing we are going to see in the peripheral blood in the bone marrow aspirate, So over here, the first cell that we are going to see is a myeloblast, which is the earliest cell, and it is largest with 15 to 20 micrometer in diameter, with a very high NC ratio, open chromatin, and containing 3 to 4 nucleoli. After this, we are having a cell which is larger than the myeloblast, called as the promyelocyte, which is characterized by the presence of abundant granules. Okay, they are having more cytoplasm compared to the myeloblast and more granules, and these are the primary or azurophilic granules. Again, over here nucleoli may be present and the chromatin is still immature. The next stage, if you see, is a stage wherein, if you will see, secondary or specific granules appear, and over here the nucleus is not having any kind of indentation. The nucleus is also more coarse compared to the previous two stages. Okay, and the nucleus is eccentrically located and there is no indentation in the nucleus. Cytoplasm is relatively greater in amount and contains both type of granules, both primary as well as secondary granules. It is also the last cell which is capable of cell division. After this, we are having the metamyelocyte. Again, the nucleus will become more coarse and they start to develop some indentation, but the indentation is less than half the diameter of the whole nucleus, and they are containing numerous amount of secondary granules. This is followed by the band form, if you can see, where the indentation of the nucleus is more than the diameter of the nucleus, and they contain secondary granules. That is followed by the formation of mature neutrophils, which is having subdivided nuclear lobes joined by thin chromatin strands with a coarse chromatin pink cytoplasm containing numerous specific granules. Okay, after this we are going to see, just like how the neutrophil is maturing, how there is a maturation of neutrophils, similarly there is a eosinophiloblast, there is a eosinophilic promyelocyte, eosinophilic myelocyte. Okay, like this we are having the other stages of eosinophil as well as basophil. Like we are having the neutrophilic myelocyte. Okay, we are having eosinophilic myelocyte and basophilic myelocyte. Similarly, we are having neutrophilic metamyelocyte, eosinophilic metamyelocyte, basophilic metamyelocyte. So the basic process is similar to the neutrophils, just with few differences in the granules. So for example, this is a eosinophil. So the various stages in the maturation of the eosinophils, if you see, these are the eosinophils in peripheral blood. Okay, so the various stages are similar to the neutrophils, with primary or specific granules first appearing in the myelocyte stage. Now the mature eosinophil is 15 to 16 micron, is slightly larger than a neutrophil. It is usually bilobed. There are 2 lobes only, and they contain numerous orange-red granules, as you can see in this particular image. The eosinophilic granules, they contain major basic protein that is toxic to many parasites, and they are basically having an anti-helminthic activity and allergic response. Then we are having the basophil. Now stages in the maturation of basophil are similar to the neutrophils. Now what is very classic about it, that they are 9 to 12 micron in size, and the cytoplasm is filled with densely coarse purple black granules, which is completely obscuring the nucleus. You cannot even see the nucleus. Okay, nucleus is having either 2 to 3 lobes, and these basophilic granules contain histamine and heparin. Basophils play a role in allergic as well as anaphylactic reaction, that is an immediate type of hypersensitivity reaction, that is type 1 hypersensitivity reaction. Now we are going to see about monopoesis, how the monocytes are formed. So again, the first stage is that of a monoblast. Again, any blast, they are having immature chromatin, they are having multiple nucleoli, and the cytoplasm of the monocyte series, they are basically grayish, pale grayish, and they have a ground glass quality, and they have vacuolation. Now this is the monoblast, which is the first cell. Then we are having the promonocyte. Now the classical thing about the promonocyte is the folded nature of the nucleus, or flower shaped nucleus that we can see. You can see, okay, if you see three-dimensionally, the nucleus is folded in case of promonocyte. And if you see at the monocytes, they are having a more mature chromatin. Now remember, in the books and from childhood we have seen that classically the monocytes are having a kidney shaped nucleus. No, this is not true. The nucleus can have various shapes. The nucleus of a monocyte, they are recognized in the peripheral blood by their larger size, by the character of the cytoplasm, which is having a ground glass pale grayish appearance. Okay, different shapes of the nucleus, but the nucleus is coarse. Okay, it is coarse, it is not open chromatin, it is coarse. Okay, and sometimes it might be vacuolated as well, as it is shown in this diagram. So what are monoblasts? They are large cells with round to oval nucleus and abundant cytoplasm that is containing vacuoles or few granules. Okay, they are having more cytoplasm than we normally see in a typical blast such as a myeloblast. The chromatin pattern is very fine, and as you will expect in a blast cell, they are also having nucleoli. Promonocytes are a little smaller than the monoblast, and they have less abundant cytoplasm, but the most distinctive feature is the nucleus, which has a convoluted folded appearance that I have already discussed. Now this is how the monocytes appear. Now remember, monocytes, in most cases they do not appear like kidney shaped nucleus. The shape is somewhat like this. So how do we recognize them? They are the largest white cells in the peripheral blood, around 15 to 20 micron in size, with irregular shape, oval or kidney shaped nucleus, and very fine reticular chromatin. Cytoplasm is abundant, as you can see, with bluish grayish appearance with a ground glass appearance, and they often contain few azurophilic granules and vacuoles as well. Now after migration to the tissues, they are called as macrophages. Monocytes basically function as phagocytic cells, antigen presenting cells, and they also produce a variety of cytokines. Now let us see the process of thrombopoiesis. Now herein the first stage is that of a megakaryoblast, which is composed of prominent nucleoli, immature chromatin like any other blast, followed by a promegakaryocyte, and finally we are having a megakaryocyte. Now megakaryocyte are one of the largest cells present in the bone marrow, and over here this is actually a single cell containing many nucleus, and the platelets are formed by cytoplasmic fragmentation, as you can see in this particular image. So let us see a few points about thrombopoiesis. So platelets are produced by cytoplasmic fragmentation of the large cells in the bone marrow called as megakaryocytes, which in turn is derived from the megakaryoblast. Now, although the nucleus of the megakaryocyte divides, the cell division does not occur, so that a very large cell with multiple nuclear lobes are present. That is called as, there is an increased ploidy. Okay, and this is called as endomitosis. That is, there is division of the nucleus, okay, without division of the cell. Now megakaryocyte is the largest largest cell occurring, or largest occurring cell in the bone marrow. Okay, each megakaryocyte produces around 4,000 platelets during its lifespan. Now thrombopoietin regulates the growth of the megakaryocyte, and remember, the major source of thrombopoietin is the liver. Now the lifespan of the platelet is around 7 to 10 days, and the cells of the megakaryocyte lineage, they express certain markers like CD61, CD41, 42, and von Willebrand factor, which is factor 8 related antigen. Now let us understand about the process of lymphopoiesis. Now just pay a lot of attention over here. Now we are having two main types of lymphocytes. One is a B lymphocyte, one is a T lymphocyte. Now let us try to understand how they are, how they mature, how, from where they originate. So both B lymphocyte as well as T lymphocyte, they are originating in the bone marrow, but the B lymphocyte, they mature in the bone marrow, whereas the T lymphocyte matures in the thymus. And ultimately after maturation, they are going into secondary lymphoid organs like the lymph node, spleen, liver. Okay, so if you see over here, the first cell we are going to start with the B cells. So B cells are originating from the common lymphoid precursor, giving rise to the B cell. That is forming a BLB, that is a precursor form of B lymphocyte or lymphoblast. It is a B lymphoblast that is going to give rise to a naive B cell. So what is it that is happening at this level? That your precursor B lymphocyte, that is the lymphoblast, is giving rise to naive B cell. Actually over here there is something called as a VDJ rearrangement. There is a antigen receptor rearrangement which is taking place at this particular point. Once the antigen receptor rearrangement takes place, which is called as the VDJ gene arrangement, the precursor lymphoblasts are called as naive B cells. These naive B cells, they mature and they now enter the lymphocyte, the lymph node. They will enter the lymph node, and first they are entering the mantle zone of the germinal center. That is, just outside the germinal center is the mantle zone. First, the naive B cells are going to enter the mantle cells, okay, and they will form the mantle cell layer. Once they are stimulated by the antigen, they are going to convert the primary lymphoid follicle into the secondary lymphoid follicles, okay. That is, there will be formation of a germinal center. In the germinal center, the lymphocytes are going to proliferate, giving rise to centrocytes, centroblast, immunoblast, okay. And post stimulation, they are going to further mature and form post germinal center B cell, that is the marginal zone B cells, okay. So these are the different forms, and once post germinal center B cells are formed, after the marginal cell stage, they are going to travel back to the bone marrow and give rise to plasma cells, which are the antibody producing B cells, okay. This is the basic idea about the development of the B cells. Now now about the T cells. Now T cells, remember, they are originating from the bone marrow, but for maturation they are coming to the thymus. Now the maturation of the T lymphocyte is not that much difficult. First of all, they are double negative, that is, they do not have CD4, they do not have CD8. Then they become double positive in the maturation process, that is, the cells are having both CD4 as well as CD8, and finally they mature to form two forms. One is the CD4 plus T cell, that is the helper T cells, or they form the CD8 plus T cell, that is, an individual cell will just have a single type, either they will be CD4 or CD8, and CD8, if you remember, that they are cytotoxic T cells, and they are now going to come and they are going to occupy the paracortical region. So this is all about the development of the lymphocytes. Now this particular image, do not get confused. Why have we, this is a normal process, and remember, why is it important to understand the normal process of lymphopoiesis? Because all the tumors of the lymphocytes, okay, they are named according to their origin, as you can see over here, okay, they are named according to their origin. That is why we have to understand this particular chart. So B cell development, if you see, there are two stages of B cell development. One is the antigen independent stage that was occurring in the bone marrow, where there was a VDJ antigen receptor rearrangement, and there is an antigen dependent stage which is occurring in the peripheral lymphoid organ, that is in the lymph node, in the germinal center. There was a somatic hypermutation taking place over there. So basically there is a heavy gene rearrangement that I told you already. There is an antigen receptor gene rearrangement, okay, that is taking place in both B cells as well as in case of T cells it takes place, okay. In case of B cells, the antigen receptor is formed by the antibodies at the surface of the B cell, that is there is a heavy chain gene rearrangement and there is a light chain gene rearrangement. Now following the expression of TDT that happens in the lymphoblast stage, okay, and HLA-DR, there is a sequential appearance of antigens as the B lymphocyte mature. So there will be development of CD19, CD10, CD20, okay, and plasma cells, they express CD38 and CD138. The details of the lineage specific markers will be discussed in the end of this video. Please stay tuned till the end. Now regarding the T cell development, as I told you, the precursor T cells, they are transported from the bone marrow to the thymus where maturation occurs. Initially, if you see the immature thymocytes, they are expressing CD7, TDT and cytoplasmic CD3. Subsequently, okay, now this stage where they are expressing CD7, TDT and CD3, they are double negative. They do not have CD4, CD8. Then they will become double positive. Subsequently, both CD4 and CD8 will be expressed. And with maturation, they are going to form either CD4 plus T cell or CD8 plus T cell, okay. This is the total maturation and development of B cells and T cells. Now remember that there are three main types: B lymphocytes, T lymphocytes and natural killer cells. Now B lymphocytes, they comprise 10 to 20% of the lymphocytes in the peripheral blood. In the lymphoid organs, they are located in the superficial cortex, germinal centers, mantle zone of lymph nodes, follicles in the spleen, and mucosa associated lymphoid tissues in the GIT and respiratory tract. On antigen stimulation, the B lymphocytes differentiate into plasma cells that is going to produce immunoglobulins or antibodies. Now T lymphocytes, they comprise 60 to 70% of the circulating lymphocytes. In lymphoid organs, they are located in the thymus, paracortex of the lymph node, periarteriolar lymphoid sheath in the spleen. Now T lymphocytes are responsible for CMI or cell mediated immunity. They also regulate the humoral response, that is the B cell response. Now the T lymphocyte precursor cell can differentiate into different types, like the T helper inducer cell, okay, that is the CD4 plus T cell, T suppressor cells, and cytotoxic T cells, which are the CD8 plus T cells. Natural killer cells are comprising about 10 to 15% of the lymphocytes in the peripheral blood. NK cells can attack and kill virus infected cells and some neoplastic cells with previous sensitization, without previous sensitization. Now this is how the organization is, okay. This is the basic organization of a lymph node. So let us see how the basic organization is. So the first thing is that the lymph node is composed of many kind of primary follicles. So what is a primary follicle? Any follicle without any kind of germinal center is called as a primary follicle. And remember one thing, that the primary follicle do not have any kind of antigen stimulation. Now once this particular lymphocytes are exposed to some kind of antigen, they are going to form secondary follicle. So what is the difference between primary and secondary follicle? Secondary follicle is characterized by the formation of a germinal center, and this germinal center contains proliferation of those cells which are exposed to that particular antigen, and they will undergo what is called as somatic hypermutation. That is, they are going to develop only those particular lymphocytes that is specific for that particular antigen which has stimulated the formation of the germinal center, okay. And if you see, surrounding the germinal center we are having the mantle cell zone, that is the mantle of small b lymphocytes, and outside this mantle cell zone we are having the marginal zone, okay. Now if you see, this is the paracortical area, if you can see, which is containing the T cell, okay. Now on the outer aspect we are having the cortex. So the primary follicles are contained in the superficial cortex. So this is the cortical area, and this is the medulla on the inner aspect. Now if you see, at the center of the medulla, okay, we are having a medullary sinus, and outside if you see the lymph node, there is a capsule surrounding the lymph node, and if you can see, at the center is the medullary sinus, okay. Now if you see the lymphocytes, okay, on the peripheral blood smear, two types of lymphocytes are distinguished, small and large. So the majority of the lymphocytes are small, as you can see in this diagram, around 7 to 8 micrometer. Now if you can also see, the basic size of an RBC is like the size of the nucleus of the small lymphocyte. Remember, these cells are having a very high NC ratio and very thin rim of deep blue cytoplasm, as you can see in this image, and the nucleus is slightly clefted, and they are coarsely clumped chromatin. They are having a very coarsely clumped chromatin. Whereas the large lymphocyte, if you see on this diagram, they are 10 to 15 micrometer in size, having a more abundant pale blue cytoplasm which may contain a few azurophilic granules. Now the nucleus is oval and often placed on one side of the cell. Now let us see the bone marrow organization. So we have read about the genesis of the different kinds of blood cells. We have also seen how they look in the bone marrow or in the peripheral blood. So now we want to see where are their location, what is their address in the bone marrow. So first, this is the bone marrow. If you can see, on the upper end is the trabeculae or the cortex in the endosteal region. Then we are having an intermediate zone, then we are having a central zone, okay. So from the periphery towards the center, what are the components? Remember, bone marrow is located in the intertrabecular space. So what is the trabecular? Let me show you. If you see, these are the two trabecula. In between the two, we are having the bone marrow elements, okay. These are the bony trabeculae. The one which is shown in pink are the bony trabeculae, okay. So basically, the bone marrow is a basic structure which is located in the intertrabecular space beneath the cortex, having three zones. The endosteal zone, which is basically containing the early granulocyte precursors like the myeloblast, promyelocytes. There's an intermediate zone which is composed of maturing granulocyte series like the myelocytes, and the erythroid islands are there. And they are having a central zone which is composed of mature granulocytes, okay. They are having precursors like the metamyelocytes, band form segmented neutrophils, okay. So we can say that the maturation of the granulocytes is taking from the outer endosteal to the central zone, okay. So the most immature forms are present at the periphery in the endosteal region, whereas the more mature forms of the granulocytes are present in the central zone. Accompanied by them, they are having erythroid islands in the central zone, and we are having megakaryocytes. Especially in the central area, we are having sinuses or the blood vessel or the blood sinusoids are there, and megakaryocytes are abutting very close to the sinusoid, so that the platelets are directly released into the sinusoids by the megakaryocytes. Okay, so this is one trabecule, this is another trabecule. The bone marrow is contained in between the two. Now this is the central area containing the erythroid islands and the megakaryocytes, and this is the endosteal region containing the immature myelocyte precursors, immature myeloid precursors, and in between there's an intermediate zone containing the maturing granulocytes along with the erythron. Okay, now the hematopoietic growth factors. So what are the hematopoietic growth factors? Let us see. We are having certain selected hematopoietic growth factors like interleukin 2, which is acting as a growth factor for activated T cells. Granulocyte monocyte colony stimulating factor, it is a multilineage growth factor for neutrophils, monocytes, eosinophils, red cells and platelets. We are having a granulocyte colony stimulating factors, which is a lineage restricted growth factor for neutrophils only, and we are having a monocyte colony stimulating factor, which is a lineage restricted growth factor for monocytes or macrophages. Now we are having erythropoietin. Remember, it is a growth factor for erythrocytes, and 90% or the major secretion of the erythropoietin is taking place from the kidney, whereas 10% secretion occurs in the liver. So the major source of the erythropoietin is the kidney. Similarly, remember, the major source of thrombopoietin is the liver. Although both of them produce, but the liver is the major source of thrombopoietin, and these are acting as the growth factors for the platelets. Now these thrombopoietin is acting on the stem cells or megakaryocytes or platelets via a receptor called as MPL receptor, known as MPL receptor. Now let us look at the normal physiological hemoglobin variants. So as we told, in the embryonic life up to 12 weeks intrauterine life, we are having 3 embryonic forms of hemoglobin, that is hemoglobin Gower 1, 2 and Portland. So Gower 1 is zeta 2 epsilon 2, Gower 2 is alpha 2 epsilon 2, Portland is zeta 2 gamma 2. Okay, that is zeta 2 gamma 2. Okay, so it is zeta 2. So Gower 1 is zeta 2 epsilon 2, Gower 2 is alpha 2 epsilon 2, Portland is zeta 2 gamma 2. Okay, HbF is basically alpha 2 gamma 2, and it is a major hemoglobin in fetal life. It starts declining after 36 weeks of gestation and constitutes less than 1% in adults. Now HbA is alpha 2 beta 2, and it is a major form of hemoglobin in adult life, and it forms the major form of hemoglobin by 3 to 4 months of age. Whereas HbA2 is also seen in adult life normally, and its percentage is around 2.5%. It is alpha 2 delta 2. So normally the adults, they are composed of 97% HbA, 2.5% HbA2 and 0.5% HbF, whereas the newborns, they are having 80% HbF and 20% HbA. Now we are going to end this particular lecture by reading about the lineage markers. Very important slide. Now although there are lots of lineage markers and there are more subdivisions, please remember this. This is going to help you a lot. Hematopoietic stem cells are positive for CD34. Myeloblast is positive for CD13, CD117 and CD33. Lymphoblast is positive for TDT, both B lymphoblast as well as T lymphoblast. Okay, myeloid series, they are positive for CD33 and MPO. So any myeloid cell, whether it be neutrophils, eosinophils, basophils or monocytes, all of them will be positive for CD33 and MPO, myeloperoxidase. Okay, monocytic series are positive for lysozyme, CD14, 16, CD11C, CD33. Erythroid series is positive for CD71, glycophorin A, hemoglobin A. Megakaryocytic lineage is positive for CD42B, CD41, CD61, von Willebrand factor, that is factor number 8 related antigen. The B lineage series, okay, or the B lineage lymphocytes are positive for CD19, 20, PAX5, cytoplasmic CD22, CD79A and CD10. T lineage cells are positive for CD2, 3, 5, 7, 4 and 8. NK cells are positive for CD16 and CD56. CD45 is present on all leukocytes, so it is a leukocyte common antigen. CD30 is an activation marker which is present in activated B cell, T cells, monocytes as well as Reed-Sternberg cells as well as the variants. CD15 is also present in granulocytes as well as it is present in classic RS cells and variants. And plasma cells, they contain CD38, CD138 as well as cytoplasmic immunoglobulin. So with this we are going to end this particular lecture. I hope you have enjoyed this very informative lecture, and if you do like, please do not forget to subscribe to my channel, and please do share, and in case of doubt please do comment in the comment section. Thank you very much guys.